The cardiac cycle is going to be incorporating ECG, so monitoring so we know what's going on, looking into the actual intrinsic conduction system, and then bringing it into the idea of systole and diastole, the contraction and relaxation aspects. Systole, contraction, diastole, relaxation. So looking at this diagram, what we have here is the light green is ventricular diastole, while the darker green is ventricular systole. So we're focusing on the ventricles for that coloration. Now there is atrial systole and atrial diastole. That's the kind of inner portion right here. So starting off, first things first, the very top is the start. You start with the blood heading into the atria. And at this point, eventually you're going to say, okay, the atria need to contract. That's atrial systole. Because this entire time, blood flows in, blood flows in, blood flows in, but we start to contract. So you have this passive blood flow going in all throughout atrial diastole. But then at the very end of the ventricular diastole, the atria is going to contract. That pumps the blood down into the ventricles. So then the start of the ventricular systole is when you have the ventricles start to contract. They're trying to push the blood up into the vessels. That's going to then end in relaxation, which is your ventricular diastole. So let's try to look kind of step by step through here, because these are overlapping. So you got to kind of think about atrial systole as one thing and ventricular systole as another. Because how do the atria work? How do the ventricles work? But they work together. They overlap. So one single cardiac cycle, you're going to have the atrial diastole. That's back with atria is now relaxing. But you notice this whole thing is atrial diastole. The atria are in relaxation for the vast majority of the whole entire cardiac cycle. The only time they're in atrial systole is right when the P wave starts. The P wave initiates, so that SA node, the P wave initiates, and the SA node initiates atrial depolarization, or atrial systole. It continues the PR segment, keeps contracting all through. But when you hit that QRS complex, here's the changeover. Atria will change over and start to relax. You change from atrial systole to atrial diastole. But at that same time, because now the QRS complex is saying, hey, we're going to start ventricular systole. We're going to depolarize the ventricles. So that's the point where you start ventricular systole. And now the ventricles are contracting from this point, that QRS complex, all the way until the T wave. Because remember, the T wave is going to be the end of ventricular systole, or ventricular depolarization. The T wave is when you will eventually start ventricular diastole or ventricular relaxation. So this is one single cardiac cycle. Atria contract first, atrial systole, then ventricle contracts, ventricular systole. The relaxation has to occur after the systole. So how do we kind of know when this is occurring? How do we monitor this externally? Well, you can hear a heartbeat. The heartbeat can tell you when you're changing from systole to diastole. Because the heartbeat, that lub-dub, lub-dub, that's telling you when the valves are closing. The first sound, the lub sound, is when the AV valves close. Remember, the AV valves are the right and left atrioventricular valves. Think tricuspid on the right side, bicuspid on the left side. Those close when the ventricles will initiate their contraction, because they're trying to prevent backflow from going up to the atria. So that lub sound, that first bit of the heartbeat, lub-dub, the lub, is when the ventricles start to contract and the AV valves snap shut. That's the first heart sound. You now know that you're in ventricular systole. The second heart sound is when the semilunar valves close. The semilunar valves are going to close after the ventricle finishes contracting. So at the end of ventricular systole, or the beginning of ventricular diastole. Because right at the end, as those ventricles finish contracting, when they start to open, you got to make sure that blood doesn't come back down. So those semilunar valves snap shut to prevent backflow into the ventricles. That's the dub sound, the lub-dub. That dub is the second one. So both sets of valves, the semilunar valves and then the previous ones, the AV valves, are based on the heart sound. AV valves close first, semilunar valves close second. But it's all based on ventricular systole closes the AV valves. And then the end of that, where you start ventricular diastole, closes the semilunar valves, atrial and pulmonary valves. Now, a heart murmur. A heart murmur is a lot of times when the valves aren't quite working properly. They might not close all the way, and there's a little leak in there, or maybe one flap is kind of moving around. But a heart murmur, a lot of times, is when there's a little bit of backflow. You're hearing that blood go backwards, a little bit of whooshing sound. Now, heart murmurs can occur from any four of the valves. Doesn't make a difference. So when a clinician is listening to your heart, they kind of move that stethoscope around. The reason they're moving it is each position can listen to a different valve. So for example, aortic valve is the intercostal space, the second intercostal space on the right side, while the pulmonary valve is the second intercostal space on the left side. You then have the tricuspid valve down here around the apex, so it's kind of midline, maybe a shade off, around the fourth or fifth area. And then you end up going all the way down, the mitral valve kind of off to the side, down around the fifth intercostal space on the left side. So each one of those positionings is trying to have the individual listen to a different valve to make sure they're all sounding proper and everything's working properly. So let's go back through the phases of the cardiac cycle. Just kind of make sure we're all on the same page here. So the first thing we're talking about is under ventricular diastole. Remember, this was the whole area was ventricular diastole, relaxation. At this point, the ventricles are simply relaxed, they're open, blood's flowing in from the atria. Now this is during mid to late diastole, not early. We'll get to that in a second. During this point, AV valves are open. So the tricuspid, the bicuspid valves, they're open. Blood is simply flowing through. It's not stopping in the atria. So when it's pouring into the right atria from the superior vena cava, the inferior vena cava, the coronary sinus, goes into the right atria and just goes down to the right ventricle. Left atria is getting blood back from the right and left pulmonary veins. Goes into the left atria and just down to the left ventricle. But then towards the end of that ventricular diastole, gotta make sure you get all that blood down. So about 20% of the blood is actually actively pumped from the atria down to the ventricles. That would be atrial systole, occurring at the end of ventricular diastole. And that's where we bring up EDV, end diastolic volume. This is the amount of blood in the ventricle just at the very end of ventricular diastole, just before it starts to contract. Now, you're saying, well, what do we care about this? This end diastolic volume will become a lot more important as we move into the physiology a little bit later, because it will vary, it will change depending on exercise, depending on stress, depending on hormones. It will vary and increase or decrease and change the amount of blood your heart is pumping out. So the end diastolic volume, the amount of blood in your ventricle, doesn't matter, they're both the same. So the amount of blood in the ventricle at the end of the diastole phase for the ventricles, just before ventricular contraction or ventricular systole. Now for ventricular systole, we're going to look at just when the ventricles start to contract. Right when they start to contract, the atria are starting to relax. The atria are going into diastole. They're going to relax and just open up, let the blood flow in. Now, while the blood is flowing in at this point, because remember, the ventricles are contracting, that means that the AV valves are closed. So the minute the ventricles start to contract, the blood is being pushed. You don't want to go backwards, so the AV valves snap shut. So all the blood that's coming into the atria at this point is just building up in the atria until it can go down to the ventricles. We hit this what's referred to as an isovolumetric phase. Isovolumetric is a contraction phase when all the valves are closed. You say, well, if all the valves are closed, the blood's not going anywhere. True. So when the ventricles first start to contract, the AV valves snap shut so it doesn't go backwards. But the semilunar valves haven't opened up yet. Because think about it this way. The aortic semilunar valve goes up to the aorta. You have a blood pressure at all times in your vessels, which means there's always pressure inside the aorta. The ventricle, the left ventricle in this case, has to contract and generate enough force to push the blood into that area that already has pressure. So let's take that hypothetical 120/80 blood pressure. 120 is the high end, 80 millimeters of mercury is the low end. That means that your left ventricle has to compress and generate up to 80 millimeters of mercury of pressure before it can push the blood into an area that already had 80 millimeters of mercury. Because you can't open that valve until there's enough pressure to displace what's above it. So as the heart contracts, it's generating enough force to open that valve and push the blood out of the way that was already there. And it keeps contracting, that's why your pressure goes up. 80 up to 120, because the heart generates even more pressure. So that is what's occurring during this ventricular systole. You have the isovolumetric until it reaches enough pressure to open the semilunar valve, the aortic valve. That then, once you open the valve, you've met that pressure minimum. That's known as the ejection phase. That's when the ventricular pressure has become higher than the pressure that was out in that vessel, the aorta or the pulmonary trunk. So you force the semilunar valve opened and blood is leaving the ventricles. This now brings up end systolic volume, ESV. Now this is the opposite of EDV, obviously, because we're now at the end of systole. How much blood is left in that ventricle after the full systolic contraction? So looking at how much blood is left over. And there's always be some, because your heart simply can't squeeze every last drop out. It can't close all the way down. It's a chamber that gets smaller, but it can't get down to zero. So the end systolic volume, how much blood is in the ventricle at the end of ventricular systole. So how much blood's there just before it goes and relaxes. And then we have this third phase of the cardiac cycle, the isovolumetric relaxation phase. During the isovolumetric relaxation phase, the ventricles are now relaxing. So I started the beginning of ventricular diastole. Ventricles open up, relax, which means the atria can dump blood back down into the ventricles. Because the bicuspid and tricuspid valves, they open back up again. The ventricles are not generating pressure. So the isovolumetric relaxation. Backflow of the blood, though, from, for example, the aorta and the pulmonary trunk, is blocked because the semilunar valves have closed. So as the ventricle starts to open, semilunar valves snap shut to catch the blood from coming back down. Remember, all four of the valves, their purpose is to prevent backflow in the system.